exploring the spinal cord and CNS. Let's dive into spinal cord anatomy, focusing initially on the dorsal columns. The dorsal columns carry fine touch, vibration, and proprioception, crossing over in the medulla. The spinothalamic tract transmits pain and temperature sensations, crossing at the spinal level. Corticospinal tract controls voluntary limb movements, crossing in the medullary pyramids. Lesions here result in the loss of proprioception and vibratory senses. Damage to this tract leads to contralateral pain and temperature loss. Corticospinal tract injuries result in spastic paralysis and a positive Babinski sign. In the midbrain, third nerve palsy leads to a down and out eye position. A sixth nerve palsy in the pons prohibits eye abduction, indicating a serious condition. Medulla damage, like in lateral medullary syndrome, causes dysphagia and sensory loss. Cranial nerve reflexes play crucial roles. For instance, the corneal reflex involves V1 and 7. The cerebellum is key for coordination. The vermis manages posture and gait. The intermediate zone controls limb coordination, while lateral hemispheres plan fine motor tasks. It processes input from spinal cord and cortex, using Purkinje cells for output. Cerebellar lesions result in intention tremors, dysmetria, and ataxia. The thalamus relays crucial information to the cortex, like sensation and vision. VPL relays body sensations, while VPM handles facial sensation. The LGN processes vision, and MGN handles auditory information. Damage in the thalamus often results in contralateral sensory loss, known as thalamic syndrome. The CNS blood supply is vital. The anterior cerebral artery supplies medial frontal lobes. Middle cerebral artery damage can cause face and arm weakness, along with aphasia. Damage in the posterior cerebral artery leads to contralateral hemianopia with macular sparing. Lacunar strokes manifest as pure motor or sensory deficits and are linked to hypertension. Watershed areas between major arteries are at risk of infarction during hypotension. The visual pathway travels from the retina through the optic nerve to the occipital lobe. Visual defects vary. A nerve lesion causes monocular vision loss, while a chiasm lesion causes bitemporal hemianopia. Lesions at the tract result in contralateral homonymous hemianopia. Meyer's loop leads to upper quadrantanopia, while Baum's loop causes lower quadrantanopia. Occipital lobe lesions typically lead to homonymous hemianopia while sparing the macula. Brown-Sequard syndrome is a result of spinal cord hemisection, causing specific sensory and motor losses. Syringomyelia results in central cord lesions causing a cape-like loss of pain and temperature sensation. Horner syndrome is characterized by ptosis, meiosis, and anhidrosis due to sympathetic chain damage. Multiple sclerosis involves CNS demyelination, with optic neuritis and internuclear ophthalmoplegia as common signs. MRI and CSF tests revealing oligoclonal bands are pivotal in diagnosing multiple sclerosis. Understanding spinal cord and CNS anatomy is vital for recognizing neurological conditions. Educators play an essential role in imparting knowledge about complex nervous system functions. Hands-on learning with models enhances understanding of anatomical structures and their functions. Let's summarize the fascinating insights into the spinal cord and CNS we explored today. Sharing knowledge and engaging discussions deepen our understanding of neuroscience. Continue exploring the wonders of neuroscience and its impact on the human body. Check out additional resources to enhance your knowledge on spinal cord anatomy. Remember, knowledge is the first step towards understanding and innovation in healthcare. Thanks to all contributors and educators for making complex topics accessible. Don't forget to subscribe for more insightful content about neuroscience. Until next time, keep learning and exploring the incredible world of the nervous system.